This is Samantha Walther, and my topic is over mandated nurse-to-patient staffing ratios. Why is nurse-patient staffing ratios important? Adequate nurse-to-patient ratios can come with reduction of medical and medication errors, decrease the risk of patient mortality, readmission, and decrease the length of stay for patients. It can reduce the risk of hospital-related complications that can be prevented, such as pressure ulcers, falls, and hospital-related infections. Staffing ratios are designed to improve patient quality of care as well as nurse retention. Nurse staffing ratios require a minimum number of nurses to a specific hospital unit for a specific shift based on the number of patients. In January 2004, the first bill to mandate nurse-to-patient ratios took effect in California. With help from the California Nurses Association and Dr. Linda Aiken, they worked hard to examine the nurse workload of 3 different states: California, New Jersey, and Pennsylvania. Dr. Aiken examined patient mortality, fail to rescue events, and incidents where the healthcare team failed to notice symptoms or respond adequately. "90% of nurses say they do not have time to provide adequate comfort and emotional support for their patients and family members. 86% of nurses say they can't spend as much time on patient education as would be ideal. With appropriate staffing ratios, helps achieve important improvement on staff and patient quality of life. This can administer high quality and cost-effective care while minimizing the risk of burnout among staff. So personal experiences that I have when it comes to inadequate staffing ratios. Currently I work as a relief charge, and when I make assignments for my staff, I sometimes feel unsafe about the assignments that I'm making. Like most of the other ICUs where I work, we could get a critical patient in at any minute, and the most stressful part of making assignments is, do I have a nurse who can take care of the patients? Take care of like a critical patient with the patients that they already have? Or do I have nurses that can absorb patients depending on how critical the patient that comes in? The hospital that I work in, most of the ICU charge nurses do not take patients, but as of lately, we all have been having to take a full assignment of our own. And I find that it makes it more difficult to do the job as a charge nurse, to be able to help and support the staff, especially when it comes to critical patients when I have to take my own assignment. Personal experiences that I've had previously. I used to work on a med-surg unit as an RN, and I worked both day shift and night shift hours, and we could have up to 7 patients at any given time. But this doesn't include the constant admissions, discharges, and transfers. We could have spent most of our shift charting on a total of 10 patients. I would leave my job worried that I missed something, or my patients were not happy with their care. Concerned about things like, did I give them turned enough? Was the aide able to do the things that I wasn't able to do? And sometimes I would leave, worried about my license and if it was being at stake. Again, currently working in an ICU setting, we can have up to 3 patients, which at times can be very manageable, depending on acuity and stability of the patients. However, when 1 or more patients are critical or have high demands, it can be very difficult to balance and make sure all patients are being adequately cared for. We don't typically have an aide to help us at night, so it's one of those things like falls and pressure ulcers could easily be avoided, but if we don't have the staff that we need, they aren't avoided, and it's not really an adequate excuse to say that we were busy. There are 14 states that currently address staffing in the hospital with official regulations. There are 7 states that require hospitals to have staffing committees responsible for plans. California is the only state that stipulates in law and regulations a required minimum nurse-to-patient ratio to be followed at all times. Massachusetts has passed a specific law to ICU required a 1-to-1 or a 1-to-2 patient ratio depending on stability of the patients. Minnesota requires a CNO or designee to develop a core staffing plan with input from others. These standards are similar to the Joint Commission standards. New Mexico has charged specific stakeholder groups to recommend staffing standards to the legislator. Kansas is not a part of any of these categories, and this map down here kind of indicates what states have passed some type of legislation related to nursing staffing. According to nurse.org, this is the proposed federal RN ratio. So, ICUs are 1-to-2. Telemetry and step down are 1-to-3. Med-surg are 1-to-4. Other units 1-to-4, rehab 1-to-5, and pediatrics 1-to-3. So what goes into staffing decisions? There's more than just what's listed here, but number of patients, severity of illness, family and situation needs, safety, education requirements, treatment requirements, observation or intervention requirements, the intensity of the situation, patient satisfaction, nurse satisfaction, is there ancillary and support staff available, and number of RNs, and their role of skill competencies. So again, why safe staffing ratios are so important. 1 out of 5 nurses leaves the nursing profession altogether within 12 months of receiving their license. 1 out of 3 nurses leave within 2 years of starting work. Nurses get burnt out easily from being overworked and pressured to take on more work than they feel safe. It's important because we can, reduce the risk of infection, medical errors, and even death. And we can provide higher, better cares for higher patient satisfaction and higher nurse satisfaction. These are my references.